Well, good morning, everyone. My name is Scott Stuewe. I'm President and CEO of DirectTrust. Got a very exciting panel for you this morning. We've got four really extraordinary folks that I want to get an opportunity for them to introduce themselves, but they represent some of the most active health information exchanges that are in use in the United States. So very excited to have Santifer from Arkansas, and Micky Tripathi, Dan Paoletti, and Ryan Bramble. Can I ask each of you to spend just a couple of minutes introducing yourself and your organizations? If we could start Ann and Micky, then Dan, then Ryan.
Sounds good. Thanks, Scott. Hi, everyone. I'm Ann Santifer. I am the director of our Health Information Exchange in Arkansas, which we call it SHARE. SHARE is unique because we are part of the health department, which places us in a good spot during the COVID pandemic.
Great. Hi, everyone. I'm Micky Tripathi. I'm currently the Chief Alliance Officer at Arcadia. Prior to that, I ran a nonprofit organization called the Massachusetts Health Collaborative, which was involved in a lot of health information exchange activity over the years. I currently sit on the boards of Commonwealth, the Sequoia Project, HL7, and run the Argonaut Project as well. And I was the founding CEO of the Indiana Health Information Exchange, IHI, way back in ancient times, and delighted to be here.
And good morning, my name is Dan Paoletti. I'm the Chief Executive Officer of the Ohio Health Information Exchange. We run the Ohio Health Information Exchange, which is called CliniSync. And we are currently working with 156 hospitals and thousands of providers across the state and health plans in a very collaborative effort to share data back and forth. Glad to be here.
Good morning, everyone. I'm Ryan Bramble. I'm the Executive Director of CRISP DC, which is one of the HIEs affiliated with CRISP. I also have a product development role for CRISP as a whole in the health information exchange activity we're doing in all of the states we serve.
Great. Thanks to all of you for being here and for being a part of this conversation about how health information exchanges are playing a role in this COVID-19 era in particular. So in fact, our first question, I want to kind of get everybody an opportunity to let us know, how have HIEs really been innovating in the COVID-19 era? What have you seen that is happening that's kind of unique to the COVID challenge? And then what lessons can we take from that that aren't necessarily, once we pass from this period of craziness, what lessons do you feel like we've learned from that COVID-19 stuff? Why don't we start with you, Ann, and we'll go around the same circle.
Sounds good. Thanks, Scott. Yeah, so when the pandemic started emerging here in Arkansas, as health information exchanges, our role is to share information. So we immediately started thinking about who needs to know this, right? So providers really have to know when their patients have tested positive for COVID. And as these testing are being done in these tents and these events, by the health department, that information was not being shared back with the provider community. So we started pushing out reports actually via DirectTrust secure messaging to every provider, every primary care physician, specifically in Arkansas, started receiving daily COVID reports on members that were attributed to them, whether they were Medicaid or Blue Cross or Centene members. Every day they get a report from us to let us know, hey, here's your members have tested positive for COVID. And also on the other side, labs were popping up all over the nation testing for COVID. So we started facilitating that exchange and connecting to labs so the health department could receive that information electronically. So being able to quickly adapt to the needs of the population and understanding what information we're gathering and who needs to have access to that information.
Great. Micky, or any of the rest of you have some thoughts about what's happening here?
This is Dan. I'll go ahead and jump in. In Ohio, we had a very active hospital association and Department of Health and research facilities that were part of state medical schools that really jumped in very quickly to help provide a lot of data. So our role was really identifying what was missing. And from a health information exchange, because we were connected to so many facilities and non-hospitals, our niche became providing testing data early on, surveillance data, and then also looking for those patients that were testing positive. We would receive that information from the Department of Health, as well as what was flowing through the network, and look for comorbidities of those patients to see if we could identify trends of comorbidities and ethnicity and location, things along those lines. And so we, again, tried to find that gap in providing daily surveillance files. With the flu season coming into, just the beginning of flu season, the state has reached out to us to look at providing similar flu type, influenza type of information so they can start to track really hotspots between the flu and COVID. And I think HIEs can serve a really interesting role with looking at things like that because of the breadth of stakeholders that they work with.
I think similar to Dan, we had an experience like that in Maryland, especially. I think one of the interesting things that we didn't expect was that having access to most providers having access to the HIE already facilitated a couple of use cases that the state wanted to pursue around statewide testing and ordering tests, and being able to immediately enable any provider in the state who already has access to the HIE to order a test from a state-run COVID lab test became a quick value add for the state. In that we deployed that quickly, and many providers are ordering tests to drive through testing sites. So I think what we're seeing is really state folks and district folks seeing the HIE as a public health utility now in light of the pandemic, and being able to rely on us for data they need, like race and ethnicity data we might get from hospitals that don't come in on lab tests and those types of things, and filling in the gaps like Dan mentioned. So it has changed things substantially, I think, as far as a shift towards how HIEs can support public health.
One other thing that we at HIEs that we have is demographics information, right? So for contact tracing, that really plays a role where we can provide the health department with demographics, phone numbers, addresses on patients if they, say, get a bad phone number from a lab result, things of that nature.
So I intentionally hung back because I wanted to hear from everyone else, because one of the things that sort of occurs to me as I sort of am kind of a third party to this, I'm not directly working for an HIE, but observe a lot of them, is that sort of the beauty and the difficulty of the role of HIEs. I think as we think about in a national emergency like this, is the beauty is the heterogeneity, right? That each of them are sort of focused on what the local need is and sort of the local landscape. And that's the curse as well, that we don't have sort of a nationwide sort of system that sort of says, how do we bring this together in what arguably is sort of would have been the golden moment for this kind of technology, and in a way that I think none of us would have anticipated even just 12 months ago. So I hear these great stories, which is fantastic, of the different things that are going on, but so much of it depends on who are the stakeholders involved. Like as Ann pointed out, she's a part of the Department of Health. That's a really different dynamic than other HIEs that have a little bit of an arm's length relationship with the Department of Health or with Medicaid. And then architecture also matters. Some are repository, some are not repository. That also has, sort of a real influence on what you're able to do. If you don't have access to the data itself, you're just a conduit, your ability to do any kind of analytics or surveillance or anything like that is highly, highly, highly circumscribed. And then also the types of patterns that you support. There are some HIEs that don't really support direct messaging as a part of that HIE function. They don't have kind of the push capability. They're more of a query response kind of capability. And that also lends itself to different kinds of capabilities. So I think that's part of the challenge as we think about COVID and the different effectiveness and different programs that we're seeing across the country that are hosted by the local HIEs.
And we are getting a question in the chat. Dan sort of suggested that maybe you could kind of share what are the major gaps you've observed in the COVID-19 related reporting. So what's kind of still missing that needs to be filled in?
A couple of things. One, not so much a gap, but a lesson learned is data standards. So I think this country has done a wonderful job of pushing interoperability. We also need to push the data standards and conventions and definitions a little bit harder, trying to normalize a lot of the information flowing through the system so it could be used from an analytics perspective, I think is one of the big lessons. I would say the other big gap is, you know, we found a lot of ambulatory practices, regional labs, a lot of folks who've never had to do reporting before, all of a sudden found themselves in a need to report. And if they weren't connected to us, it became more of a burden for them to report. So I think as we look into the future and as soon as the vaccination reporting, you know, how do we, again, continue to push interoperability? And if we look at vaccinations like in post-acute care space, where a lot of vaccinations are going to be provided and maybe aren't normally provided, it's going to be critical to really bring them into the ability to be interoperable and share information. As Ann mentioned, not just from a reporting perspective, but it's critical for those providers caring for those patients that the information flows back to them. And that was, again, I think, another lesson learned. How do we make sure that those primary care providers do know what's going on with their patients?
Great. I think as a segue to another topic we wanted to discuss, I think you've raised some interesting questions. So in the health information exchange environment, I think there has been a shift away from merely exchanging data to doing a lot of other value-added services. And I think that this is in particular seen as a path to sustainability for some of the HIEs, that there's relevance to be had in the local copy of the data and how that can be. So what I think is of interest here is if you could share which of the kind of value-added use cases those capabilities have made the most impact in terms of promoting the relevance of your organizations or organizations you've observed, and how does that impact the sustainability question? Anybody want to start?
I mean, I'll go first. Definitely working with health plans, working with payers is key for sustainability, right? And it's a benefit to both, because it seems like payers here in Arkansas have suddenly woken up and realized, wow, this HIE can be beneficial. It can help me. It can help me reduce some of my costs, and maybe can even help me generate some revenue, right? So if we can retrieve medical charts from providers and deliver them to the health plans, rather than the health plans contacting the providers directly or getting access to their EMR, it streamlines that workflow. It reduces the cost on the provider. It reduces the burden on the cost on the payer, and it reduces the burden on the provider, because now they can just do what they like to do, which is take care of folks. And the HIE is retrieving information that the payers need, that they're going to request. Maybe they need it for HIEs reporting or for Medicare Advantage risk adjustment. And we can deliver those charts electronically to them. They can, do their risk adjustments on their patients. They can help close some of those care gaps. So, and then also we have health plans actually paying for providers to participate in the HIE because they know that is valuable to them. So that's kind of where we are in Arkansas, where payers over the last, I would say, 8 to 10 months have really woken up to this idea. And maybe COVID had something to do with it. Maybe, the providers are just not as welcoming them into their practice like they did in the past. But I feel like it's definitely key for our sustainability.
I have a couple of thoughts just in our experience on that. And those are definitely use cases I think HIEs pursue and we've tried to pursue. And there's always some, there are always a few roadblocks to supporting HIEs as an HIE, be it around verification of the data or source verification of the data, and is it something the payer can take, or do we need to get some sort of certification? We've had issues really trying to get ECQMs utilized by providers in the community is another potentially value added use case for the HIE. I think we're still finding value add in intelligence, but still exchange. So being able to use the data we have to determine that a patient might need a second lead screening, or a patient might have had an overdose, or being in the EHR so that when you're prescribing an opioid, it tells you that the patient might have had an overdose. And those are things you kind of calculate with data you have and are value added, but aren't sort of big data in the traditional sense. And so we're seeing some value in those use cases specifically.
Yeah, I'll jump in. I think both points that were made around this are really important. The value is interesting because every community is a little bit different. Every stakeholder is a little bit different as far as what they're looking for. And being able to be, I think, that trusted entity that the stakeholders have faith that the information flowing through the network is going to be used in a way that helps everybody be successful, but makes everybody feel really good about sharing information is pretty critical. And that's probably one of the biggest assets that we've created, is that concept of trust, and creating a bidirectional exchange between the plans and the providers, making sure that claims are now starting to flow in a way that people can consume them, bringing together the claims and the clinical data to see if that pregnant mom has filled her prenatal vitamins, allowing the data to be used for HIEs reporting in a way that is following the kind of concept of minimum necessary, which I think is a really important concept that sometimes gets overlooked. What role do we play in bringing the community together to facilitate community service support for these patients that really need more than just care by a provider, but need really support across the community? I think there's value there of being that neutral, kind of trusted third party.
I guess I think these are all great points. One thing I would note is they also point out the heterogeneity, which I'll keep coming back to, is every place is different. And I've worked with with large states where there are multiple HIEs. And what's fascinating is you have one state with a sort of a connected network, and each of those sort of local sub-state HIEs has a different sustainability equation, right? Even just for one region of the state, which I think is just sort of one of the challenges here. I kind of think of, when I think about the sustainability question, a couple of things. One is the challenge, and I would love to get all of your perspectives on this, the challenge of the commoditization of basic query response and push capabilities. So Commonwealth, care quality, those things being built into the EHR systems, that is rapidly commoditizing just the ability to query for a CCD and get it back. Right? Now there are all sorts of issues with the quality of that and all of that. Maybe that's that's one area, but it seems like there's sort of this rising tide of commoditization that needs to be addressed as you think about how each HIE sort of moves up market. And I think that even hits at some of the things that we've talked about here, for example, like the ability to have clinical information made available to payers. As I think we know, each of the EHR vendors actually has growing lines of business with payers, where they have payer solutions where they'll make available CCDs directly to payers with provider permission. So it's always trying to figure out, all right, well, how do I stay away from those businesses in a way that's sort of going to be defensible? The things that I think of when I think of potential unique things that certain HIEs might be able to do because of their sort of their local connections are, one, and with an eye toward how do I stay away from what these other very well-funded national level organizations are headed toward and doing, are one, how do we get more sort of deeper into the healthcare delivery system where care quality and Commonwealth and the eHealth Exchange aren't yet, like LTPAC, social services organizations, which are very local in nature. Now, of course, we have, Aunt Bertha and Unite Us and all of those coming in, but I think that there is something there that seems like it's very local in nature, and that's staying ahead of where those large, sort of nationwide, HIEs, HIEs are. The second is something that Anne again pointed to, is that deep connection. I know CRISP has this as well as I think clinicians, is that deep connection with the state government and those state government activities. If the local HIE is sort of the conduit of a deeper set of things that the state government, either through Medicaid and or the Department of Health, of Public Health, is doing, that seems like that's something unique that no one else can really replicate. And that is, a part of what becomes a requirement. And the third thing that I think of, and again, would love to get other people's perspectives on this, is sort of an open area right now, but again, has unfortunately been made very clear by the current pandemic that we're in, is the lack of our system to have anything related to situational awareness. And I know Ryan knows all about this because of the Sander project, but when we think about interoperability, we think about payment, we think about e-prescribing, we think about clinical interoperability. But now, as we've seen, we don't have anything by way of a nationwide system that tells us how many beds are available in this region, how many ventilators do I have, how do I think about, sort of shifting capacity. Every city, like the city of Boston, has, ED, kinds of relationships where they can shift capacity, but that's very, very local and varies a lot by city. And that seems like, I wonder if that's an opportunity for HIEs to be able to provide that kind of situational awareness in their states, for example.
I'd love to jump in and respond to a few of those, Micky, because you made some really great points there. So, I am on the care quality steering committee as involved in care quality as you are. And I do think that, they're very much targeted. All the national networks are very targeted on the commodity of exchanging CCDAs. And I think the local HIEs can add a lot of value on top of that. It can even plug into those networks to get data from places that we have not been able to get, or it's been costly to get data out of ambulatory space. And so I think your points are valid around what kind of services and data can we offer on top of that. Certainly being tied into Medicaid in all of the regions we serve has been very helpful in having access to claims data as a supplement to that data exchange, the public health data as a supplement to that data exchange. And I think you make a really valid point about situational awareness. It's all forms right now. Every SNF census, how much PPE do you have, ventilators, it's all forms. We're lucky that in Maryland, we're collecting that data for folks. I think the local HIE offers a real trusted third party where not only can you submit that data through the HIE, but the HIE will have that local awareness to know all of the facilities that need to be engaged and submitting that data. And doing that on a national level sounds very, very hard to me. There are lots of data elements that need to be captured that are not standard, are not going to be in a CCDA, and facilitating that through the local HIEs makes a lot of sense. I know the ONC has really been advocating for that, and we appreciate that. So I think those are all really good points. There's a lot more I could try to talk about there, but I think we're very much in line with what you're saying as far as the value of the local HIE in conjunction with the national efforts. It's not a competition for us.
Yeah, I think so. This is a segue actually into kind of one of the things we wanted to specifically ask, and some of you've kind of already addressed it, but the sort of the question of the national efforts and what the HIEs are doing to engage with them, or how they see them as relevant to what they're doing. Including, obviously Chic as a not-for-profit trade association that supports the HIEs, they're present in the marketplace, but in terms of the national network efforts, including DirectTrust and Care Quality and Commonwealth, and I think that understanding how you all think the HIE needs to, how do the national efforts and the regional efforts need to interact, and what is the bushing there? What's your approach to engaging with those?
Yeah, we welcome it. I think the national players are here, and we just have to learn to play well together with one another. I think finding our own unique set of abilities of things we can do that are different from them. Our unique way of being able to push information to providers, to payers, that is only on their relevant members, sets us apart from the national players. But we don't have everybody connected, and people are going to travel and they're going to get sick in other areas. So national organizations are great for that, and it just only makes our data better and more richer.
Yeah, I'll jump in here. I think we're a little different when it comes to the majority of HIEs, in the sense that we got started with federal and state funding, but for the last 7 years, we've been independent of any kind of federal state funding. So the services we provide are paid for by the stakeholders, and they do a really good job of telling us what they need and what direction they need us to head. I sit on the board of DirectTrust and on the board of HIEs, and we are a big believer that if we can't help our stakeholders be successful with using the national networks, direct messaging, carrier quality, e-health, that we haven't done our job. So how do we complement and bring more value to those services? How do we maximize the investments that the EHR vendors have made in those networks, and can we bring additional value in turning not just data but data into information that can be actionable? And there was a question around standards a little bit earlier, and I'll just say we haven't fully adopted LOINC coding and SNOMED coding. We're not fully on the same way that we put discharge status and admit source in our ADT messages, and making all that information, pushing data standards so we have more commonality as data flows through the network is going to make it easier for these national networks to make the information usable. But until we get to that point, that's part of our role. Can we take that information, join these national networks, which we are, we're big believers in all of them, and take that information and make it more readily usable for bedside care and for analytics. And again, pushing the envelope about where we need to be and what services we provide that are valuable enough for people to want to keep us around.
Yeah, the term national networks is almost a misnomer for me personally. It's very valuable for us. You think about HIEs and the regional data exchange we can do on encounter sharing, cross-border, not really national, but I mentioned it earlier, the value of Commonwealth and care quality is really connecting to those local networks of providers that cannot afford or shouldn't have to pay to do a proprietary connection to the HIE. And so to say, oh, go to the ECW practice with 10 docs and say, you just have to connect to to care quality and we can exchange data with you. You don't really have to do anything special. And so really the value for us, one of the value adds for us in the national networks is just getting into the vendors that are local. And there's definitely a role there for them and for us.
I think it's a great point. I would just, sort of an observation, and I think it's really true, and hopefully will help to break. But I know there doesn't seem to be any hesitancy on this phone of all of you as leaders of HIEs to actively participate with the nationwide HIEs. But I've heard of others who may have a little more hesitancy. I was very involved with the effort to bring Commonwealth and care quality together and to get them to connect up so that the user experience is as a single network. And I know Scott in his prior life was involved in that as well. And one of the things that we found, which was a big challenge and a hard conversation to have at that time, but I think it's borne itself out in the same way that the internet itself has borne itself out in terms of the kind of value it delivers, is that there was concern that, is that going to undercut my business on either side? And I'm not criticizing either one, but there was concern of, well, now someone doesn't have to join my network because they're going to be able to get it through that other network, and maybe if there's a pricing differential or whatever. And what we've found, now that the dust has settled a little bit on that, and literally tens of millions of transactions are going across Commonwealth and care quality, is that the value to each network is actually increased. That both of them are finding that more users find them valuable. And I've been in specific conversations where a CIO has said, I wasn't going to join, Commonwealth, but because it just felt like it was too limited. But now that it's connected to care and quality, I'm going to join. So I think that there's, you know, a little bit of that. I know it's a leap of faith for a lot of people, but that has been, you know, a pretty common experience, I think, in network economics in general.
Yeah, it strikes me that a lot of the things that the HIEs do that fill in some of these gaps relate to the things that, you know, that frankly commodity exchange doesn't really have the opportunity to think about, and it's pretty difficult to knit together a lot of different elements. And I think that between the activities of common law and care quality and the activities of the government, the fair market value for the exchange of basic healthcare information has basically been driven to zero, which is difficult because it actually takes dollars to deploy this stuff. So it's interesting to see how all this is shaking out. Let me ask a question about how do we utilize the infrastructures that we represent to drive equity and address systemic disparities in care. What do we think? The democratization of healthcare information exchange can do to democratization in general terms. Anybody have a thought about that?
I mean, I can start. I think the thing the local HIE does is it makes the data available to any provider that needs it, right? Regardless of what investments they've made. And so, access to CRISP is free for a provider in, in any area of any of our regions. And so it does break down some barriers to the information exchange. And so we can certainly help in that regard. I think we can also be involved from a public health, perspective in providing data about patients who are sick. And we're seeing this now with COVID-19. All the states we work with have asked us for the demographic data for these patients that are coming down with COVID, and the disparities are clear. And hopefully we have data sets that can help really identify those in more targeted ways. Social determinants is a huge effort for us in the district, and making sure that there's a free and easy way for a provider to refer someone into a food insecurity program or housing insecurity program, and for the fact of that enrollment to be communicated to the whole care team. And I think those have been efforts that we've been gotten a lot of support from DC Medicaid on, and they're very key to these issues and understanding these issues in their population. And so I think there are a number of things we can be doing. I think these are starts. I hope that, it might take a year or two for really these social determinants networks to feel more like regular interoperability, where I'm in my EHR and I can refer someone to a program, and they might use Aunt Bertha or they might use Unite Us, and it just flows through the HIE just like it would flow between ECW and Greenway. And that's kind of the way we're thinking of things here in the district.
Yeah, I'll just kind of jump in here too. I believe that we have a role. Our board last spring, really recognized that healthcare disparities, equity, racism is a public health crisis, and we have to do something. We have to change the way we're doing things. And they've really pushed us to kind of understand what our role is in that area. And we've been interviewing so many different stakeholders across the continuum, technology vendors. And what we discovered in Ohio, like most states, there is a lot of incredible work going on. A lot of people doing great stuff, doing the right thing, yet it's not aligned across the state. And what we need to do is figure out from a standards-based approach, how do we allow the data to flow from the providers to the community services, to the plans, to anybody who needs to support that patient from a standards-based approach, and allow those that are using a Aunt Bertha or Unite Us or Healthify or whatever it is, if it's in this different programs in the same city, how do they talk to each other? How do we allow anybody participate in a way that, again, is a standards-based approach and push standards? I can't stress enough, the 360X direct project that I think will allow EHRs to EHR referrals to flow. We're a big believer in that, and we're trying to get everybody to understand it, learn about it, the Gravity Project, Da Vinci Project, all these great efforts. How do we push them to a faster pace, get them adopted quicker? And I think that's an interesting role for us, because in some cases we don't really have a direct work effort in it. We find ourselves more in a facilitation role.
I'll just go back to COVID for a second, because when labs and providers started reporting COVID results, race was something we were not seeing across. So that was one area we were able to assist with, providing that demographics information. So then the health department, knew, hey, we have an overwhelming number of Hispanics who are testing positive. So additional efforts were put around supporting the Hispanic community. Or we also have a large Marshallese population here in Arkansas. So identifying who those folks were and then targeting them for COVID related education was really important. So it varies.
I have a little bit of a different example, but I think it just points out, I guess maybe a couple of things. One is, I completely agree with Dan's points of, we always need to do more in standards, but just to show how sort of the development of standards over time is something that now we can sort of utilize to make greater progress on equities issues, for example, as well as how HIE infrastructure can help to be an important piece, but not the whole solution. So in Massachusetts, we have the Mass Highway, which is, it's called an HIE, it's a HISP. Are they part of DirectTrust yet, Scott?
Yes, they are.
Oh, hallelujah. Okay. So part of a HISP that's a part of DirectTrust, and the Boston Public Health Commission in 2006, I'll try to make this a very fast story and not give every year since 2006, but in 2006, they promulgated a regulation called, they called for the calculation of what they called the Boston Health Equity Measure Set, which was a tool that they wanted to use to be able to collect data from all the hospitals and the health centers in the city of Boston, so that they could calculate clinical measures stratified by fairly fine-grained race, ethnicity, language stratifications, so that they could then identify, sort of hotspots from the perspective of inequality, tool to better allocate their public health resources across the city of Boston. And one of the things that they found in 2006, literally, this regulation was promulgated. If you look up Boston Health Equity Measure Set, you'll Google that, you'll find it. And one of the things they found when they passed that was they immediately were confronted with the fact that EHRs didn't have the standards or the capabilities to deliver that data, as you can imagine, back in 2006. And so that regulation literally sat on the shelf. And then in 2014, they dusted it off and said, hey, now we have continuity of care documents, and we have this statewide infrastructure called the Mass Highway, which at least can be a single conduit for people to trigger those CCDs and push them to us in as much of a commoditized transport mechanism as possible. We can hire a vendor that will aggregate that data for us and calculate these measures and do it, according to those REL stratifications. And that's what they're in the middle of now. They're just about to select a vendor to do that. And then they hope to push forward using as much of that sort of HIE infrastructure as possible and as much of the standards as possible. The point is that those aren't perfect by any means, but they can help, sort of create, sort of remove enough of the friction that you actually can move forward in a really substantive way.
Great, thanks very much for this. Now, so we're getting kind of down to the end where we've got maybe 10 minutes or so before we might want to open things up to, we've got a few questions accumulating. I'm going to let those accumulate, and let's just ask sort of a closing question for each panelist. I think my interest is in knowing sort of if you had a magic wand and you could say, okay, I want one thing. So maybe we're looking for two things. So one thing that you would like to be able to do that if your organization or an organization that you have something to do with, what would you like that organization to be able to be successful at? And then the next question, and you can answer either or both of these questions and give it to each of you. The other is, what about the government? What could they do for you? What that they haven't done? So they've made it, illegal for folks to hang on to data. So the question of whether or not data hoarding or data sharing is a thing, it seems now at this point to be maybe that's a thing of the past potentially. But interested in knowing each of your perspectives on those things. So Tell us about your magic wand. What does it want? Each of you.
I'll go first. If I could wave a magic wand, I would make integration possible without any sort of EMR fees. I know the national organizations have that ability, us local folks don't. That tends to be a barrier. We're getting better at getting health plans to remove those barriers for us. And then just from the health department, I would like fax machines to go away because it's really hard to count COVID test results when we're getting thousands of faxes a day. So that would be my genie wish, for fax machines to disappear.
Okay, that's a good Christmas present. I'll go for that. Who else? Dan, you're muted. There you go.
Thank you. If I had a magic wand, and I think I'll combine what I would ask the government to do, is align the Part 2 data, behavioral health information that could be exchanged like any other data that's overseen by HIPAA. I think the not having the ability to exchange that information for care hinders a lot of work and really hurts a lot of things. And there's some efforts, we're really close to that. But if we could make that information follow the patient for care, I think that would do a tremendous amount of good. And then the other thing I would say just on data hoarding, we've never really seen that as a problem in Ohio. I think stakeholders across the state really believe that it's the right thing to do to allow data to have access to the information and to follow the patient. And recently ONC just published a white paper looking at interoperability in large cities across the country, and Cleveland was one of the cities they looked at, and it was indicated as the most interoperable city, a large city in the country. And I think that goes to prove that, given the opportunity, everybody is working really hard towards this, and it can really benefit the patients. So
I think for me, the magic wand, which is really just going to be lots of hard work we have to do as the HIE, is some of the things Dan was talking about earlier around data quality and really hammering through the data we get and trying to standardize it, especially in the CCDA. I hope that as FHIR becomes a method of folks transporting data, and as the Care Quality puts out its FHIR implementation guide, that we have much less variation in the standard exchange parameters. It is just a lot of work. And to be totally honest, we didn't prioritize that work in the beginning. We were prioritizing just connectivity, but now slogging through the data quality work, it would be really great if that could just be fixed. And I think on the government question, I absolutely echo the 42 CFR Part 2. Glad to see there's some movement in that direction now, and really look forward to that data being open. And I'll just reiterate a point earlier. I think the continued advocacy from the federal government as local HIEs is supporting public health. It really does seem to me that is going to be something that is not going to go away, and is something that we can continue to serve a really strong role in the future.
So I think mine are going to be a little bit more practical. So one of my wands, I would want to make all of yours come true. So that would be the first one, because I agree with all of those, and I think that'd be great. I guess one that sort of occurs to me, maybe it's the first one, is the government one, is I would want the information blocking rule to apply to payers as well. There is a ton of information that payers hold in terms of claims data that would be incredibly valuable to HIEs and to everyone else, right? All the fee-for-service claims and all of that claims, it gives you an incredible breadth of information on what's going on with patients that's now just stuck within, payer organizations. The only claims data they make available is those are in risk contracts for the most part. So that would be, sort of one of my wishes. The other, I think, would be related to information blocking as well. And, perhaps it's providing that pathway so that participation in some type of formalized HIE that's connected to a nationwide network. So whether it's Commonwealth, Care Quality, one of the HIE, one of your HIEs that's connected up to one of those gives a safe harbor with respect to information blocking, because I think that's the one missing link that provides that connection that can be really important to make everyone participate. And maybe that's a part of TEFCA. Right now it's not, so we have a little bit of gap there. And I think that could be something that could energize people's motivation to be participating in some type of HIE, whether it's a local one or a national one or both.
Great. Well, that does sound like some really good wishes. So a couple of questions kind of from the audience that I'll ask. One is specific to how, to what extent do patients have direct interaction with your HIEs? Those of you who run them, are there what role do patients have at this point?
Yeah, so CMS released some new rules saying, patient access needs to be improved. I don't ever want to be in the business where we have direct patient access to the HIE simply because that would be a huge undertaking. So what we're doing is we're feeding clinical data back to the health plans as they develop, like our Medicaid agency is developing an app that Medicaid patients will have access to their claims. We'll be feeding clinical data to it to enrich that claims data. But I don't ever see ourselves giving access to patients to the HIE.
Yeah, in Ohio, that's similar as well. The relationship has always been between the patient and the provider. So the providers have the ability to pull all the information down from us and then in turn make it available to the patient. And we think that's really where the relationship should stay, is between the provider and the patient, or the provider and the plan, or the patient and the plan. So that's how we make it available to the patient.
We also don't today have a direct relationship with patients outside of consent preferences. And we'll be expanding their consent preferences soon with 40 CFR and aligning with those rules. There are requirements coming that HIEs are that have to follow, and so there will be some level of patient access. I do think there are some very legitimate concerns from providers about patients accessing their data through a third party, and what diagnosis is the HIE sharing with the patient that the provider didn't want to have shared yet. And so that's a real conversation that has to happen. But I would expect that will probably look like API type exchange through some method the patient prefers. To us, that's the way of doing it, as long as we can validate, as long as there's security in the apps or whatever is being used by the patient. But as of today, we don't have anything other than consent preferences. It's definitely changing in 2021.
Yeah, I think it's a really interesting and hard question. I'm glad, Brian, you pointed out that the regulatory, it's still a little bit sort of ambiguous about how much of that applies, and specifically with respect to patient access and how sort of direct that has to be. But I think that is a real issue, not just for HIEs, but for anyone that might fall under that clinical integrated network, and even companies like Arcadia, like us. We're an aggregator of data, and arguably would fall under that umbrella well. So we have to have to think through, how does that actually work, and what does that mean for us? I can certainly appreciate, and I don't know if Ann and Dan, a part of your concern with patient access is the whole issue of identity proofing and all that, which is a real challenge. I mean, it's just an enormous challenge. And I'm still, it's not clear to me how much demand there is from patients at the end of the day to do this, but that feels to me like something the market should decide, that patients should be given access, and then let's see where they go with it. I actually like the model of, I think, Brian, you were alluding to this, of, sort of the apps that provide that level of service of identity proofing or whatever, and then through a trust mechanism can be trusted by others to say, well, if one record did that, we trust them, and they can query for a record just like any provider can query for a record.
I think everyone on the phone has the benefit or the risk of being an HIN. I think we're all HINs. In fact, there's probably everybody who's who's attending here probably has something to do with an HIN or is one themselves. And that is that implicates us all in the information blocking rule, as much as that is confusing for a lot of folks, particularly the HIEs and an organization like DirectTrust. We're both in circumstances where what does it mean to be an HIN, and how are we implicated in the information blocking rule? So it's a hard question, I think, to grapple with, and I do think that there will be some marketplace work on that. Let's see, we do have a couple of other questions. I think relative to social service organizations, there's sort of two questions here that relate to that, I think. So the question is about the tech that they have, and I think this is also true in public health, right? So if you don't have two dimes to rub together, you don't have a lot of systems. Your system might be Excel, and a direct address. I mean, so that might be what you have. And so the one question is, are we finding the social services organizations have any tech? That's the first question. And the other one is, can push messaging help them as they, kind of move up the scale? Those are two questions coming in the chat. Any thoughts about those?
Yeah, I can jump in because we're doing a lot of work in this space, and the community service organizations are going to fall in one of two buckets. Either they do have technology that can be integrated, or they just don't. So if you look at the 211s, some of the food banks, some of the other agencies that use technology that runs across the country, those are technology stacks that definitely can be integrated with either directly or through one of the community service vendors. But then you have a lot that aren't. So a lot of these smaller ones need support. They need web-based applications that can allow them to interact in a way that information can flow bidirectionally. So it really runs the gamut to both extremes, is what we're finding.
Yeah, you definitely have to be flexible and meet them at their technology level that there are. Like Dan mentioned, whether it's a web-based application that all you need is internet to log in, or, I've talked to Scott a lot about this. We're big fans of DirectTrust secure messaging, and we open that up to various community services because that's low tech. We can push information to them that's relevant on their members. So you just have to be able to be flexible and meet folks of where they are.
Yeah, I definitely echo both of those comments about those organizations, and sending direct messages is definitely a solution for a lot of them. On the public health side, there are certainly antiquated systems there too. And we find ourselves, being almost a middle layer where we're interacting with an older database to pull data out and then putting a modern API on top of it. And there are some of these surveillance systems that are older and that require some level of modernization. And so I think it depends from organization to organization, but there is some stuff the HIE is able to do to help uplift that system to have a more modern API on it, as we're talking about, sharing that information.
I think it's a huge challenge still. I mean, I think it's obviously getting better, but I spent many winter months traipsing around New Hampshire when we were working with the New Hampshire Health Information Organization, may it rest in peace. And we had offered direct messaging to them at no charge, kind of, like what you're describing, Anne. And had said, we'll just, we have a web portal. You can use that as a, sort of a webmail surface. We'll connect up the hospital. We'll do all that. It seemed like a no-brainer. And there were more nursing homes than I care to count that we went through, did the presentation. They said, that's great. We only have one computer, and it's in the back office. We have a fax on every floor, though. You can send us faxes. Beautiful. Anne, I can see Anne just dying here. But if it happened just once, I would think that's an anomaly. It happened more often than not that we had those hard discussions, that even webmail was difficult. The other more positive story I would tell is, I'm not pitching a company, but I think, Patient Ping is an example of a company that I think has done a really nice job with the SNF network, where they've set up the ability for them to generate ADTs essentially, or pseudo ADTs on a portal and integrate that in the network. And that's a ton of hard, roll up the sleeves work, which is really, really painful. but like once you build enough of it, all of a sudden that's a real network that's really hard to replicate. So I think that there are models out there of, or success stories of being able to try to bridge or push as far as you can on that network to try to address that gap in capability out at the far reaches of the healthcare delivery system.
Well, this has been really a rewarding conversation. As we were putting this group together, it didn't occur to me just how broad and complete you all represent the health information exchange community. Certainly amongst the health information organizations that are successful, you guys represent the kinds of organizations that are really kind of making things work out there. So thanks for all that you do. I know we're supposed to end a little early so that the next thing can happen. So I want to thank everyone for coming and all of you for participating in this conversation. I thought it was, for me, very, very rewarding to hear your thoughts about all of this. So thanks so much. And thanks for those of you who attend at home. We're eager to hear what you think. So let us know. Thanks very much, Scott Stuewe for DirectTrust and for the Health Data Unbound conference. It's been great to be here. Thanks.
Thank you.
Bye.
Thanks, everyone.